First of all, be all welcome to this X-ray seminar. It doesn't, it's not meant to be like an X-ray seminar itself. It's more focused on osteopathy because most of these are going to be pictures of dysfunction that are going to give us pain, but they're not going to be necessarily osteopathic dysfunction. So it's differential, what we use for differential diagnosis, okay? So I think we should start with that. It's a huge presentation. So hopefully I make it attractive for all of you. So first of all, we have to know what is normal between coma, which is the standard views of the X-ray. So they're going to be anterior, posterior, and lateral. It doesn't matter if it's anterior, posterior, or posterior, anterior. And second, we have to know what is called the different radiological colors or depth. So we have air that is going to be completely black. We have fat that is going to be dark gray. We have density water that is going to be like a light gray. We have bone density that's going to be white, and we're going to have metal density that's going to be a bright white. So where do we find air, or we must say lungs? Well, in lungs we have a mix of air and liquid. So very typical, for example, in the intestine, when you have gas, you're going to be a real black image. Where do we find fat? For example, in women's chest or even in the abdomen, we can find this fatty tissue. Water is really related, for example, with heart. Well, heart is a mix. It also may have fat, but for example, muscles, when you see perfectly these both psoas going on oblique line, and bone, you know what is bone. So when we find something bony that is not supposed to be, we find it pathological. And density metal, it should be, for example, in any prostate. So going back to the views, we have AP, we have lateral, and then we have oblique. So one perspective we have to have in mind is when you find an oblique view is because we're searching for something special or something not so common, right? So first of all, we go into the cervical region. These are the projections: AP, lateral, oblique. Then dynamic seems to search for this hernia, to search for sprains like a whiplash, and to see instabilities. And transoral, that is going to be for the upper cervical, okay? So first of all, although it seems to be like too obvious, but we have to know the normal anatomy, right? So first of all, we know the anatomy. See, you have the vertebral bodies. What is special on the cervical spine? You have the uniform processes, and you have the presence, as you can see, the cartilage of the thyroid cartilage. Here we got it, right? You may find like the trachea, if it's kind of calcium, or even the esophagus, or even you can see both vertebral arteries, but this should be pathological. So first of all, the anatomy, the distance between disc and the facets, the spinous process that has two tubercles. So we have to be that everything is in place. From the lateral view, the same. We're gonna find the normal anatomy with the normal curve of the spine. We may find some the cricoid cartilage should be like with a little bit of ossification sometimes, or in some patients we could even see the esophagus. We're gonna find the distance between the anterior the anterior arch of C1 and the odontoid process. the relation between the articular processes. And as you can see here, the spinous processes, the two tubercles, instead of being on the horizontal plane, they're going to be on the sagittal plane. So this is something, let's say, special, right? And then dynamic, we see the behavior of the spine. Here I'm going to be really quickly. And during flexion, the same. During flexion, remember, it's normal that the vertebra above goes above the vertebra below. So this is really, let's say, normal, right? Let's say, there's people asking for this. So this is what we find, let's say, normal. Why do we need an oblique view? For example, in cervical, we want for the intervertebral foramen to see if is there any osteophytosis from the vertebral body, the unciform, or the facets. So here we see an oblique perfect view of the intervertebral foramen. So why we can use this to see if is there any contraindication on the manipulation or not. And as you can see here, there is no contraindication, so we can thrust with no problem. And the transbuccal or the transoral is for the upper cervical. Anytime we have like whiplash, we should have this because sometimes they're hidden. So we ask the patient to open the mouth and we see the odontoid process, the body of C2 and the lateral parts of the atlas of C1, right? So whenever you see this picture, we have to suspect because these are the teeth, right? And this is a transoral or transbuccal view. Thoracic region, here we have AP, lateral, and we also have teleradiography full spine. When or why do we have this teleradiography? Tele, remember, means from distance, and this is when you want to have a complete view of a spine and both lower limbs. For example, when you're searching for an scoliosis or for an scoliotic adaptation. Okay. So here we got the frontal view. It is going to be different than the thoracic view. When we make a thoracic, we want to see or take a look to the lungs, the heart, but this is mainly for the bony parts. So you can see the vertebral bodies. As you can see, again, the normal anatomy. What we see here is that the distance between vertebral bodies is narrower because here the discs are narrower because we don't need too many, well, we don't need the disc because we have the ribs. And as you can see, this seems to be the eyes of an owl are the pedicles, and the nose or the beak of the owl is the spinous process. Remember, from T1, T2, it's at the same level, and then it's going even 2 levels lower to go back just 1 level up, right? Lateral view, again, to see if we have any rib fracture of the distance, or even if you're finding a tumor, or even the kyphosis, if it's normal or if it's normal. If we go to lumbar region, again, the same as cervical, plus teleradiography. So in a frontal view, we're gonna see the vertebral bodies. First of all, we have to count if we find 5 vertebral lumbar vertebrae, or 6, that would be a lumbarization, or 5, that would be a sacralization, right? And again, we're gonna see all the structure. Remember, physiologically, the facets are gonna be in a sagittal plane. Here you got it. And you may find what is called a trapezium, that one of the facets should be in a AP plane instead of in a sagittal plane, right? We're gonna see the transverse processes, the spinous processes. So if it's all okay, or it's not a lack of fusion. And again, for example, here you see that it's not completely vertical. So this should be like an adaptive scoliosis that is not a real scoliosis. In a real scoliosis, you see a twisting of the trabeculae. And here you have, for example, a visceral ptosis, because this is gas inside of the column. On a frontal view, sorry, in a lateral view, again, we're gonna see the shape of the curve, the angle between L5 and the sacrum, the intervertebral foramen. Before MRI was so common, you can make a diagnosis of this hernia or prolapse by the sliding of the upper vertebra to posterior. So here we go, and here we say everything. Sometimes in a lateral view, you can see a vertebral rotation, because you see like a folding of this vertebra. So again, you have to see what is normal and what is not. Remember, fractures are not common to see like a smooth direction, but a sharp direction. And we're gonna see what is normal. For example, oh, sorry, I will tell you later. The bones in the first toe, the sesamoid bones, remember we are normal, that's not fracture, right? And some findings we know that are normal, that there are no fractures, okay? Or for example, if you see like a lot of pieces, maybe it's not a polyfracture, but it's a kid that they don't have all the bone parts ossified. Again, why an oblique view? Because we're gonna see the figure of a dog. Remember, this figure of a dog is for two reasons. First of all, to see the intervertebral foramen, and to see if there's a fracture of the pedicle, well, of the lamina. So the eye of the dog is gonna be the pedicle, the nose is gonna be the transverse, the ear, the superior articular process, the neck is gonna be the pars interarticularis, the frontal leg, the inferior articular process. So if we see that the dog is wearing a collar, necklace is a problem, but because it means there's a fracture of the pars interarticularis. You got the dog, the eye, the nose, the ear, the neck, that it's okay, the anterior leg, the body, and the tail, right? So knowing the normal anatomy, for example, in this patient, what we see as a curiosity here, you got the kidney, and this is a calcification of the calyx, or maybe they put some injection to see these calyces. Pelvis and sacrum. Again, AP, lateral, oblique, not very commonly used, hip axial, and pelvimetry. Pelvimetry is only used in gynecology to see if the shape of the baby's head is the normal for the delivery, right? So frontal view, what we see, because there is a lot of cartilage, we're gonna see a really wide sacroiliac joint. And this, in the second hand, we're gonna see like a not regular shape, because we know that physiologically there is not such thing as regular anatomy of the sacroiliac. We see the fourth and fifth lumbar, the sacrum, the coccyx, the alignment of the pubic symphysis and both hips. So you find what is supposed to be normal, the ASIS, the acetabulum. So for example, here you got gas from the column. In the lateral view, it's not we're gonna see the angle of the lumbar and the sacrum. So we can see if the sacrum is too vertical, or for example, in a rectification of the lumbar spine. We're gonna see the coccyx. For example, when the patient falls on the buttocks, you see an anterior subluxation of the coccyx. So we may say, or we may assume that we should have a somatic dysfunction according to the alignment. So here we find a patient with a rectified cervical lordosis, but here you see there is a problem on this on the joint, right? This is the upper cervical measurement. This is not osteopathy. This is more chiropractic, but this is the line they use. So first of all, they use a transverse line between the both the digastric groove at the temporal bone. Another transverse line is going to be across C1, and another one is going to be across the body of C2. And we're going to find a vertical line that's going to be crossing the odontoid line. Whenever this is parallel and the line 4 is vertical, it's supposed to be okay. But this should be a rotational dysfunction of axis. This is really chiropractic, because as osteopaths, we know that we may have an adaptation of the upper cervical, for example, related to an anatomic short leg or a podal short leg. And this should be normal, as long as it's mobile. And of course, this is like a playing with images. Look at my hands. If my right hand is closer to the camera, you see my right hand that should be bigger, but it's not bigger, it's closer to the camera. So this is the same thinking, the same thought with the transverse lateral masses. So as you can see, dysfunction in laterality, because the distance between the lateral masses of the atlas and the odontoid process is bigger in one side than in the other one. And here is a rotational. But again, not necessary, in this case, it's not necessary to be a dysfunction, but an adaptation. We call dysfunction what is a lack of movement, right? And this is a vertical view. This is really chiropractic, because it's seen from above, and you see that the atlas is not in the correct lines. But again, for us, first we have to make a movement test, and then we have to search for the 3 signs of osteopathic dysfunction. This is the angle between the occiput and the atlas. The normal between comma should be around 8 degrees. So if the atlas is going into flexion, remember the posterior part is going to be up, or the occiput is going into extension or flexion, this angle is going to be modified. In this case, for example, the atlas is going to be into flexion. So these lines are going to be more parallel. The angle is going to be inferior to 8 degrees. It means there is a dysfunction into flexion of C1. In this case, for example, if the occiput is going into flexion, that means that the chin is closer to the neck. You're going to have an angle bigger than 8 degrees. In this case, for example, you see there is 20 degrees. Maybe a postural disbalance or a trauma. In the opposite, we have an extension that is that the chin is going to be intra-anterior. Again, a patient with hyperlordosis is going to be in that position, and it not necessarily has to be into this function, but radiologically, we'll find this. We have the Halditz curve, that is the curve between the transverse process should be in an homogenical line. And remember the unfolding of the border or posterior body. Here we're gonna be quick because, well, we may find here an anteriority from T3 to T5. As you can see, there is a kyphosis, but these 3 vertebrae are like blocked into anterior. Of course, this is a corpse. Again, with the ilium, remember, the ilium is both ilia are in a relatively anterior rotation, okay? So if the ilium is going into anterior, the dimension should be, or you may find it like shorter vertically. And if you have a posterior rotation, the dimension vertically may be like bigger. This is what we have, right? So because this distance is bigger, we may presume that the ilium is into posterior rotation and the other one is into anterior rotation. But again, one thing is the adaptation and the other thing is the dysfunction. The same for internal external. Guess that you're opening a book. If you're opening this page more like this should be wider than the other one. And if this going into internal rotation, this page should be narrower. The same for the sacrum. The closer the sacrum it is, the anterior is going to be and the wider is going to be. If we're going into postural disbalance, we have what is called normal lordosis. In this case, we have an increasing of this curve. We have like spondylolisthesis. Here we got an inversion, and here we got inversion. Here we have a rectification because it's a changing of the shape, and here is an inversion. These things, this procedure happens, remember, when we're having a whiplash. Remember, we also have the measurement for the glenohumeral joint. This is the line that the homohumeral line should be aligned, and the distance of the infraclavicular distance, if it's increased, remember we have an inferiority, and if it's decreased, if it's lower to 11 millimeter, we may have that we have a superiority of the head of the humerus. And this should be a problem for the supraspinatus muscle, for example. Again, we may talk about anterior talus dysfunction because when the talus is going into anterior, you're going to have an impingement of the tibio-talar joint into the anterior. If we have an anterior tibia, the impingement should be posterior. And again, visceral dysfunction column. Here you got the ascending, well, the secant, ascending, transverse, descending, sigmoid column. First, we can see if the transverse column that should be at this height between the epigastric and mesogastric area is nearly, well, it's inside the pelvis. So we may say that the patient is suffering antosis. Because of the closing of the hepatic flexure of the column, what we have is a dilatation of the secant that may lead to a ileocecal valve syndrome. And here we have a flexure, a closing of the splenic flexure. What's the difference between the right column and the left column? The left column, the pathology of the right column, as you can see, is spasm. So you see all the ostras that are into contracture of the smooth muscle. And we could also, for those who've been studying cranial, remember, this is from the thesis of by Cristobal Gogorza, one of the professors of the UM. We may say if it's a cranium into flexion or into extension. Well, let's go into the differential diagnosis. Let's start with the coxofemoral joint. So here we got the head of the femur, the neck, the greater trochanter, and the shaft of the bone. And here you got the acetabulum. So first thing, and this is the normal AP, and then you have another one into abduction and external rotation. This is mainly to show the greater trochanter. So This is the hip projection. We're gonna see the distance. I'm gonna show you later if there is any flexure or even the angle of the neck of the hip. So this is the what is called normal depth of the acetabulum. That should be around 13 millimeters. The lower it is, the more arthrosis is suffering the patient, and depending on sex, it's gonna be wider, but this is what we call normal, right? And the measure is gonna be at the depth of the acetabulum and the let's say superior of the surface of the acetabulum with the pubic symphysis. This is the distance of the acetabulum depth. Then we have the femoral neck angle that is between the neck and the shaft. This is mainly to place the patient into groups. More than 135 degrees is what is called coxa valga, and less than 135, well, less than 120 something is called coxa vara. The younger the patient it is, the most likely to be into valgus. The older the patient, due to the lack of calcium here, is gonna be into coxa vara. The coxa valga is gonna make more pressure on the upper part of the acetabulum, the coxa vara in the inferior part. This is the Shenton line. This is, as you can see, is quite similar to the omohumeral line. Just a sec. Just a sec. The people wanting to connect. So this is the Shenton line that, as you can see, is similar to the omohumeral. This should be the alignment of the inferior part of the pubis with the neck of the femur. For example, here we have a dislocation, so this line is going to be break. And this is the angles you should take into measure. We don't need to know all of that, but this is the what is called the cover angle. So if this angle is lower, it means that it's a coxa valga. It's higher, it means a coxa vara, and it's gonna lead us to all what we said. Okay. Well, this is a dislocation, a femoral dislocation that, remember, because of the well, the bony protection and all the ligaments and wherever, it's really difficult to have a dislocation because it's more common to have a fracture, right? But sometimes you can find like this in elder patients. If we talk about fracture, the acetabulum fracture, remember the classification is according if is there intra-articular or extra-articular. Okay, I'm not gonna be too much here. Here you got the socket fracture, which is the danger of this fracture. Remember, here we have important blood vessels like the iliac artery and the branches of the iliac, the internal and external iliac arteries. So the risk of this fracture is that the patient may be dead because of bleeding, right? We also have the fractures of the femoral neck. Well, we have different classification, basifractural, polys neck fracture. So according to the neck or according to the line of fracture. As you can see, what we talked before is that this ABD, an external rotation, is used to see these oblique trajects of the fracture. The patient may have pain and impotential functional impotence. And according to the degrees, you have another classification. So this is type 1, type 2, type 3. We don't need to know this. You can find it on the books. The problem is the direction of the fracture, because could be intra-articular, extra-articular, and because of the muscle insertion, you may have displacement of the bony parts. This is a comminuta fracture, so we have different pieces, and this is the intertrochanteric. So remember, here we got the insertion of the psoas. So you got an intercapsular fracture. Remember, the capsule reaches the intertrochanteric line, so it is within the articular, the capsular part, sorry, and here you got basal cervical. It means the base of the head. This is a classification. Well, we may get into degenerative arthritis of the hip joint. The typical image is going to be like a drop that you got. So it's going to be into inferior and with the shape of a drop. This is a really advanced study, advanced stage of this. If you got the arthrosis, the head of the femur is inside, even inside the, or nearly inside the pelvis. And here you got the increasing of, well, first of all, the decreasing of the line. It means there is no cartilage. There is only calcium. So this is really a problem with pain, lack of movement, etc. You got in stage 1. Remember, in stage 1, this is only the affection of the cartilage, and then you have to, this line is going to be, the areas closer to the joint are going to be whiter, because the increasing of the pressure makes the body to develop more bone. So this develop of more bone is going to give into this whitish area. In second stage, we can have these geodas, these nodules that you have like a wound in the bone, and you see like a hollow area. But this is a real stage, advanced stage. Here you got these hollows. This is a hip that should be treated by surgery with the prostate. And the stage 3 with the osteophytes and the lack of movement, and even the degeneration of both parts, the head of the femur and the acetabulum. Well, this is a dysplasia of the coxofemoral joint. Remember, it's a lack of, well, it's a problem of the growing of the head. So you see that is this is the normal shape, a rounded shape, and here's a deformation of the head of the femur. And then you got a acetabular protrusion that is what we saw before, that is the entering of the head of the femur almost inside the pelvis. So here you got, there's no line. If you see the distance, remember that should be normal. We consider normal 13 millimeters. This is gonna be less than 2 millimeters. Again, arthritis with coxa valga, more than 135. Again, the coxa valga itself is not a problem, but it's gonna give here more pressure. As you can see, at the acetabulum is growing an osteophyte because of the increasing of the pressure. One more, even and slip of the femoral head. More chondrocalcinosis. This is a condition, let's say that it's more or less similar to gout, but in this case, the crystals are made by calcic pyrophosphate. It's a metabolic condition that is gonna be like a calcification inside the joints. As you can see At the knee, we're going to see them at the ligaments, the meniscus, the joint itself, and it's going to lead into pain. So the patient may come to the practice with pain, and when we see an X-ray, we see these deposits of calcium. And this is the hip joint of a children. Hey, what's going on here? There's a lot of fractures. No, there's not a lot of fractures. These are the areas of the bone that are not still calcified. This is a congenital dislocation. Why a congenital dislocation? Because of the shape, in this case, of coxa vara. If you think of your elderly patient, what is the risk of this patient? This dislocation and fractures of the neck. Vascular necrosis, this is a problem of a pathogen that came through the artery, and it's going to produce a destruction, as you can see, a massive destruction of the joint. And here you see the osteonecrosis. As you can see, all the trabeculae are broken, and even the superior part is apart from the bone. Again, an osteonecrosis is a pathogen came through the artery, or an obliteration of the artery. Remember, the artery comes through the ligament of the head of the neck, right? In this case, we have a vascular, that is a necrosis by lack of blood, and you can see the destruction we have here. This is a normal one, and you have here a massive destruction. The patient probably came to our practice with pain, with lack of movement, and when we see the X-ray, we see all this massive destruction. Here, the impeachment, as you can see, the distance is lower. So again, so I'm not going to stop talking about this, but you have a classification according to the type of fracture. You can check this. And here you got the paper in which you can see the classification of the fractures of the acetabulum. We've seen the dysplasia. So let's go into spinal arthrosis. You may know a lot of the spinal arthrosis. So this part we're going to be quick. This is a disc arthrosis. So it's an arthrosis of the disc due to a problem. As you can see, there's a massive destruction of the fibrocartilaginous part, and you see this on the MRI. So this is the different shapes of the osteophytes. The more typical are going to be into anterior due to the traction of the common longitudinal ligament. But you may also have lateral one, and here you're going to have, apart from these osteophytes, you're going to have sliding into posterior because the destruction of the intervertebral disc. Right? So this is typical. When you have a destruction of the disc, a posterior tilting of this part. Let's go, let's continue. Again, lateral osteophytes. This is really typical because of this is typical due, as you can see, to a discal problem. And this multiple discal problem is not because of the patient is making a bad movement. This should be like something more metabolical, like a bacterial or a pathogen translocation that attacks the disc, producing this. In this case, we have a prostate disc, and you have a reactional arthrosis, because remember, from an osteopathic perspective, arthrosis is a hypermobility. Sorry, because I forgot to translate this. Well, another pathology we may have is spondylolisthesis. We may have a lytic spondylolisthesis. First of all, spondylolisthesis, remember, is an anterior displacement of the vertebral body. is mainly occurs in L5 due to the shape of the spinal lumbar. And we have two types. We have the lytic spondylolisthesis, that it means that it's a fracture of the pedicle, and we have an arthrosical one. The lytic, remember, we're gonna see this figure of the dog with a necklace, but when it's due to an arthrosis, we're gonna see that the dog has like a folded ear, okay? So you all know this arthrosis. Look, the osteophytes in this case go into the intervertebral foramen. This is a really typical and interesting picture of the sacroiliac arthrosis. Why is curious? Because remember, from an osteopathic perspective, arthrosis is a hypermobility, and the sacroiliacs are joints that are more likely to be into hypomobility. Well, when they happen, they are more into inferior, as you can see here, right? Arthrosis, again, this is quite similar to lumbar, so we're going quickly. You know this. With the cervical, yes, we have to be aware because you have, first of all, arthrosis of the vertebral bodies, they're going to be anterior osteophyte. They don't cause any problems. Sometimes they can cause problem with the esophagus, but not very likely. And the problem is that the radiculalgia, because of the irritation of the cervical root. So we may have a compression due, in this case, to a posterior osteophyte. Why is called posterior? It's because of the direction of the osteophyte. When they are on the articular facet, they're going to be into anterior. And we have to know the direction of this osteophyte in order to use one thrust or another. So if you got cervical arthrosis, even with the lack of this lordosis. So if you have, in this case, an arthrosis due to the unciform process here, if you do a homolateral rotation, you're gonna be producing even more pain. So the thrust should be rotation into the contralateral side. If the osteophyte is posterior, it means that is the facet to the intervertebral foramen. You should perform the homolateral to take the osteophyte away from the nerve. And if you have this figure of 8 or like a sun clock, the thrust should be into side bending to open this foramen. So this is how we have to know the rotation to one side and to another side. This is the most important goal. If you don't know the direction of the osteophyte, please don't thrust or thrust into side bending. If you got foraminal stenosis due to the osteophyte. Look here, we have a figure of 8. And the patient may refer like a root problem, right? So according to the stenosis, we decide which technique we're gonna use. So again, and we're gonna talk about later on, if we have time, about the disc prolapse. But in this case, you see that it's a transligamental hernia because it's the torn of the common posterior vertebral ligament is really clear, and is the inversion of this nucleus pulposus into the canal. And here we got a subligamentarian hernia. Again, we, before MRI was so common, we could use these side signs of the X-ray. So for example, here you got a left side bulge at C6, C7, here you got. So it means that there's something there. There's like a protrusion of the disc. And here you got a bulge of C5, C6. Of course, if you want to make any screenshots, just feel free of doing. Well, here we got a disc prolapse where the arrow is. This is the longitudinal posterior common ligament, and as you can see, it's okay, it's not torn, but here you see the prolapse, making a slight compression of this. Another pathology we can find is the spinal stenosis, that is the width of the distance between the posterior part of the body and the facet that should be bigger than 12 millimeters. If it's narrower, we may have problems. And we also have the distance between pedicles that should be from 22 to 24 millimeters. This is only for lumbar spine. Okay. So this is the AP and the lateral measurements of the spinal stenosis. Remember, if this distance A is narrower than 12 millimeters, there is a problem. In this B distance is narrower than 22, 24 millimeters, we have an stenosis. So here you got a lack of distance between the A distance here due to this hernia or due to spondylolisthesis. Here you got an stenosis due to an arthrosis. Well, this is what is called a diffuse idiopathic skeletal hyperostosis. It's called also the Le Forestier syndrome. And as you can see, it's an ossification of the anterior part of the ligament, the common ligament. So the patient may refer pain, blah, 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 blah. And then when we see this X-ray, you see this anterior calcification, but the disc is not affected, right? Let's move into differential diagnosis with the first rib. So first you have here an arthrosis of the first rib, the cartilage with the insertion with the sternum. We have a cervical rib. Why do we know it is a cervical rib? Well, this is the limit, the posterior angle of the rib. If the transverse process is crossing this angle, is what we call a cervical rib. This may cause problems on the cervical plexus. And again, this is a mega transverse because it's also going away from this distance. Here you got a mega transverse processes of C7. These may cause problem with the scalene. And here you got a mega transverse plus a cervical rib. Okay, let's go. I can see my friend Nati as well. It's a pleasure to see you all here. So this is a surgical treatment for this hernia. Remember the surgical treatment for this hernia and this prostate, not really, this prostatic is not really good. Well, but you can see that. Because during flexion, the mobility is not good and the extension is not good. So in first instance, you may take the pain away, but in the end, it's also a problem. We're talking about the chronic rheumatic polyarthritis. Remember, The difference between an arthrosis is that it's a massive destruction in all the joint. And this is a real important condition in cervical area because it's going to destroy the transfer ligament of atlas. That is going to give us an instability of the upper cervical. This instability must be shown by this distance between the posterior part of the anterior arch of the C1 and the Odenton process. If this distance is bigger than 3 millimeters, it means that it's an hypermobility, there is an anterior subluxation. Please do not thrust the upper cervical. Another picture of Le Forestier disease. Remember, in this case, we have a real, the typical X-ray would be a calcification of the anterior common ligament, but the discs are gonna be intact. This is a Klippel-Feil syndrome that is called is a short congenital neck. The patient has a really typical phenotype of wide trapezius and really short neck and well, and other findings. The patient may come with the cervicobrachial neuralgia, but as you can see, it's gonna be a short neck with the fusion of 2 or 3 vertebral bodies. So please do not trust this because it's a fusion, right? You got the fusion, and the fusion. So here we can make like functional technique or soft tissues techniques to avoid pain. This is an 3-dimensional CT, sorry, of a Klippel-Feil syndrome. This is a congenital, right? And as you can see, this is a massive fusion. So the difference with Le Forestier is in Le Forestier, the discs are intact. Let's go. Let's continue. Let's continue with the knee. Remember the Osgood-Schlatter disease? That is a problem with the insertion of the quads. This case is really typical in young patients. It's because of the traction of the tendon, and you're gonna see like this. Well, this is the result of the traction, like a piece of bone is away from the tibia. Here you got what is called chondrocalcinosis. Do you remember the one what we see? These are the deposits of pyrophosphate, and the patient may refer pain and well, lack of movement. As you can see here, you have the like a calcification of the meniscus and all the soft tissues, right? Here again, and even at the pubic symphysis. So we're gonna see, just a second, please. Sorry, at 8 p.m. we have a tribute for all the sanitaries working for the COVID problem, and everybody's clapping, but it's a lot of noise for us. So you have the chondromalacia or any problem with the patella, and this is the view. So here you got, this is the femur, this is the patella, and how do we know there is a chondromalacia? First of all, because we see the increasing of this line, that means that it's more pressure, this is a kind of arthrosis. And as you can see, you have a deviation of the patella, in this case to lateral, right? And here you have even this traction. And this is an MRI of the same problem. Again, even if you don't see an MRI, it's like, sorry, I can't interpret it. Okay, but let's try to make like a homemade diagnosis. This is bone. This is these are the condyles of the femur, and this is the patella. And this is these are black because it's bony. Okay, this is a T2. projection. So we see something here behind, and well, this has to be any blood vessel. So this is liquid. And here we find liquid. So it means there is an inflammation. Why there's inflammation? Because we have a patellar chondromalacia. Well, fractures of the patella, you see when there's a solution of the continuity is a fracture. We know that the patella, some patellas may be into two pieces, but if the patient refers to trauma and then we see two or more pieces, probably is a fracture. And this is difficult to see, but we have a fracture of the tibial spine. This is due to a direct trauma. Avulsion fracture, remember the avulsion fracture are due to traction of whatever structure inserts there. So which structure is inserted into the sternal tibial plateau? The tensor fascia lata muscle, well, in this case, the iliotibial tract. So as you can see, there is a piece away from the tibia. Knee arthrosis, this is a real huge knee arthrosis. These patients usually don't come to our practice. This are really likely to have a prosthesis. Here you got an increasing of this pressure, a deviation, and as you can see, this is a lack of the smooth of the cartilage. Even you can have these pieces that go inside the joint. If you got it, an increasing on the condyle, on the external condyle, and a deviation and a lack of this height due to the destruction of the meniscus. Real big gonarthrosis with the signs, you know, the patient is going to have, you know, pain, lack of movement. We see an x-ray, and this patient could be treated. The only thing we have to be aware of the thrust technique. Which is the difference with the chronic rheumatoid polyarthritis, the huge destruction of the rheumatoid arthritis. This is a real deformation of the joint. And of course you have all the symptoms from the lab. You have an increasing of the sedimentation speed. You have the PCR is going to be higher, and the rheumatoid factor is going to be higher. Okay. You got a Pellegrini-Stieda syndrome, that is a calcification of the ligament. And then we go to some tumors. This is an osteosarcoma. This is a, if we have time, I will make you a difference between the primary and secondary tumors. So this is a primary tumor. From the beginning, we're gonna make the difference between primary and secondary tumors. Remember, primary, they have a quick growth. The youngest the patient it is, the bigger is the growth. So this is really huge, as you can see. A lot of pain, night pain, that nothing relieves pain. No medicine relieves pain. So here you got a really typical radiological sign, as you can see here, is the periosteum, is the reaction of the periosteum. When you have a fracture, the periosteum seems to be okay, only the fracture, but here you see like the periosteum is like the layers of an onion, right? So the patient is gonna be referring pain according to the structure that is into compression, the nerves and the blood vessels. Really typical, these primary tumors in long bones such as femur humerus. So osteosarcoma, Ewing sarcoma, and this had a really bad prognosis. Fibrosarcoma is another kind of primary tumor, but it is, as you can see here, there's no growth, no bone growth, but a destruction of the trabeculae. So here you see that instead of the image of this trabeculae, it's an irregular shape. The patient is gonna be referring pain. Myeloplex tumor, as you can see, you're gonna find a hollow of the long bones like the tibia and even at the thumb is what is called a giant cell tumor. Okay, it's a primary tumor, and the problem with this is that is a recidivant. So the patient gets surgery but develops again the tumor, and the typical image is going to be this hollow of the bones. Osteochondroma is a tumor of the cartilage. It's a growing of the cartilage. As you can see, it's really typical in young patients. This is the epiphysis. So this is an osteochondroma of the femur. This should be the adductor tubercle, and this is a growing. And as you can see, the difference with the bony tumor is they are not so big, not so destructive. And this should be a somatic dysfunction into laterality, into internal laterality, what we call a valgus. Is an internal deviation of the tibia. Remember, the patient is going to have an increasing of the pressure, or both in internal and external part of the knee, and because of the deviation of the axis, the patient may have pain during flexion and extension. More images. The sacrum, here we're gonna be quick. The sacralization, remember, is a fusion of the fifth vertebral lumbar vertebra, sorry, with the sacrum. Could be incomplete in this case, still with the joint, complete, and it could be unilateral and bilateral, right? And remember, one of the things you have to know, this is really important, when you see one of these problems on one part of the spine, for example, of the sacrum, take a look at the superior part, because it's really common to be in both extremes of the spine. We talk about this measurement again. If this sacrum is into oblique, it's probably an adaptation, as you can see here by the distance of the femur, of an anatomical short leg. This is the teleradiography, remember, with the short leg, so the adaptation into oblique. Again, the sacroiliac arthrosis. Well, this is really interesting, the ankylosing spondylitis. First of all, to say that it's a positive case, we have to have both syndesmophytes plus bilateral affection of the sacroiliac, right? Bilateral. The syndesmophyte is the calcification of the vertebral ligament and the disc that is going to give us the shape of a bamboo. Remember, here you got, and the ossification of the sacroiliac. So this is the normal one, and we're going to have 3 stages. First of all, we're going to have a pseudo widening of the joint space because of the osteoporosis. Remember, bilateral. Second, the appearance of a postal stamp, here you see. And finally, the bony ankylosis with the direction of the trabeculae into lateral. So this is stage 1. Stage 2, as you can see, like the postal stamp or rosary beads. You got the rosary beads, right, in a TC. And stage 3, remember, it could take like 20 years or so to get that direction. This is a joint psoriasis. That is like the psoriasis you see in a patient in the skin. It may affect the intervertebral distance of the sacroiliac. The difference is that it's going to be a unilateral dysfunction, not bilateral. The Feistinger-Leroy-Reiter syndrome, again, it could lead us with what is called the oculo-urethrosynovial syndrome. This is the complete form. You're gonna have syndromes at the eye. It's gonna be like a conjunctivitis. You're gonna have urethritis, and you're gonna have synovitis, really typical in one sacroiliac. To make this diagnosis, remember the patient should have a sexual transmission disease. This is a pubic arthropathy. As you can see, a destruction of the pubic symphysis. Then we go into avulsion fractures of the sacroiliac. In this case, if this is a fracture of the AIIS, this should be because of a traction of the rectus anterior of the quad. In this case, by adduction, it could be because of a traction of the hamstrings or the adductor magnus. Well, direction of fracture, vertical fracture of the sacrum. The vertical fractures are more stable than the transverse fracture, but anyway, the symptoms could be related to the affection of the nerve roots. Remember, S4 is going to be around the crotch or the anus, so the patient may have any kind of symptoms around this area. This is a sacroiliitis. This is the most uncommon syndrome because you may have a sacroiliitis. Remember, to the Leroy Fessinger right there, you may have this due to an infection or an inflammation of the column or of the cecum. So, well, sacroiliac diastasis and sprains because of the three layers of ligaments, the capsule and whatever. This has to be a really high energy trauma, like a car crash, right? And these dislocations are very common with fracture. Okay, this is an open book dislocation. More differential diagnosis. The shoulder. Here you got the omohumeral line, and this is the distance that should be of 11 millimeter. Of course, you have to know the normal anatomy, right? The tubercles, the bicipital groove, and in external rotation from the trocheter fractures. So here you got the fracture of the greater humerus tubercle. I had a patient that suffered this because he thought that what we saw in the film was real. So he tried to open a door, pushing with the shoulder. The result was a fracture of the great tubercle. And this is an anterior dislocation of the shoulder. Remember, the luxation of the shoulder are more into anterior and internal, well, inferior and internal, because the capsule is looser on this area. So this distance is really big, and look, the humerus is not into the position. This is a real uncommon view, right? The osteoarthritis. And it's gonna give us, because again, the shoulder is normally quite mobile. And so to have a hypermobile problem, that means that it's a real disadaptation. Well, the typical image is this drop-like image, right? This is a vascular necrosis. In this case, it's for a lack of problem with the vascularization. Remember, the rheumatoid arthritis, again, every massive distraction is like a rheumatoid arthritis. Again, osteoarthrosis with this drop-like picture and the lack of distance between the head of the humerus. An osteoblastoma is a tumor, a bony tumor. It's typical in this area. So here you got destruction or, well, fracture of the glenoid process. That's gonna give us, remember, problems with the labrum are gonna give a glenoid test positive, and it should be only the cartilage part, or in this case, you're gonna be like also the bony part. This is the head of the humerus. This is the glenoid, and this is the labrum. So here you got a fissure of the labrum. Anterior tier of the labrum here, you can see. Again, this is a lack of continuity, so we may suspect there is a problem. Again, a problem with this under rotator cuff. The Bankart lesion, remember, that is with the labrum. Calcification. Well, this we know by the normal anatomy that this should be a tendon. So the tendon is radio transparent, and suddenly we see calcium here. So we suspect there is a supraspinatus calcification. In this case, this is the bicipital, and again, an image of supraspinatus. I'm going really quick because I have a lot of pictures to show you, sorry. So here you got a supraspinatus again. The calcification of the coracoacromial ligament. In os acromiale, there is a bone that is loose into the joint. Impingement of the acromion. This distance is really low, as you can see. The head of the humerus, the acromioclavicular joint, and you see that the distance is really, really low. And in this case, this is a conflict caused to osteophytes. Why this osteophyte? Because at any point should be an hypomobility. In this case, because of the torn of the supraspinatus, you have like a disbalance of these bones, and due to the hypotonia of the biceps, you're going to have an upper head of the humerus causing conflict with the supraspinatus and with this space. Okay, normal anatomy. The distal part of the humerus, epicondyle, epitrochlea, the head of the radius, and the ulna. This is the frontal view and the lateral view. All the, again, it's like a guess that they are made from crystal, so you're gonna see this transparency. The calcification of the epicondyle could be for two reasons: for an excessive traction of these muscles, what we call an in this case of the epitrochleal muscles, and you may have also due to a lack of blood supply. You got a radiohumeral calcification that could be like a calcification of these muscles that are going to be the epitrochlear ones. Here you got a calcification of the epitrochleal muscles, so this is not a bone itself, but a calcification. Here you got a decalcification for the same reason, right? In this case, from the epitrochlear, so what is called the golf elbow. Distraction of the flexor muscles. This is a epicondyle avulsion fracture. Again, avulsion fracture is an excessive traction. In this case, could be the radial of the first and second radial, or the brachioradialis muscle. This is a fracture of the head of the radius. This is typical, falling and stopping with the hands. This is the vertical line. This is a real big elbow luxation, as you can see, with fracture of the head of the radius. This is another elbow luxation. And if we go to the upper limb, we should take a look of the distance of the carpal tunnel. These are what I call the normal dimensions of the carpal tunnel. The AP should be 0.85 centimeters, so 85 millimeters, and the lateral should be 1.70 centimeters. If these dimensions are lower, the median nerve could be into trouble and give us these symptoms, you know. This is a frontal view of the wrist, the lateral one, and then you have sometimes this oblique view to take a clear view of the first metacarpal and the navicular bone of the wrist. This is the normal alignment of the carpal bones line. Again, you should know the normal anatomy. This is the radius. This is the ulna. So this is a navicular luxation. Semilunar luxation. As you can see, there's a quite lack of order in these lines. Again, another one. Perilunar luxation. So as you can see, there's a lot of space and lack of these two lines of bones. Pisiform luxation. This is typical. Sorry, the pisiform luxation due to attraction of the cubitalis and cubital anterior muscle. This is the potocoles fracture. Really, this is a fracture of the distal part of the radius, typical in elderly person. And it's gonna give us this image like the neck of a swan. This is a radial styloid fracture. This is mainly made by a radial deviation movement. This could be, for example, like a butcher or somebody using a hammer. A navicular fracture, the same, because of falling on the head. The problem with navicular fracture is that the patient may have with a normal activity or almost normal activity of the hand, and the problem is that could evolve into an osteonecrosis because of the lack of blood supply in that area. Again, a navicular fracture, as you can see here, instead of hey, these are two bones. No, remember the navicular has the shape of a bean, and then you see there is something there. Another navicular fracture, right? This is a Kienbock disease that is an osteonecrosis of the semilunar bone. Why do we suspect? So you see the normal bones, and here you see more white bones. That means that something is making more condensation. This is a Kienbock disease. The patient refers pain, and well, there's another conditions that related to this. This is a CT of a necrosis of the navicular. As you can see, there is a lack of fusion of the fracture. The Bennett fracture is a fracture of the first metacarpal, and the deviation of the bone is going to be linked to the insertion of the adductor. Here's the Bennett fracture. So the line is really typical, and it's typical when doing a ski or we're falling on the hands. This is the Roland. As you can see, the Bennett is more intra-articular, and the Roland is more of the neck or more close to the base. The trapezium fracture, again, these all traumas are falling with the hands, and the problems with the thumb are more, for example, with the ski, when with the leash of the ski is hitting the hand. This is an arthrosis of the first metacarpal. Remember, pain, lack of movement, or a lot of swelling, and you see the reduction of the line. Here the same with a little bit of subluxation. Remember the tumor of the giant cells with the hollow wing. Of course, it's gonna give us pain, and when we see that, this is a, well, it's not a second metacarpal base, but a first, second, and third. Probably this is somebody fighting, right? And as you can see, there's and here the same, a metacarpal neck fracture. This is, most of the time is for a fight. In this case, you can see the metacarpal shift fracture. In this case, is the third, and also the fifth. This is really typical in fights. Montagia's fracture, this fracture of the olecranon. Again, this is really typical. The fifth metacarpal is typical from somebody who doesn't know how to hit when fighting, and instead of fighting with this part, is hitting with the lateral one. So the fifth metacarpal breaks. Phalanx fracture. This is, for example, typical in, when you're hitting a ball with your hand, or a direct trauma. An interphalangeal luxation, if you have even if you have treated basketball players or handball players, this is really typical for putting the hand and the ball is hitting the hand. Look, this is a luxation plus a fracture of the base of the phalanx, and this is a massive luxation, as you can see. The fracture of a phalanx. The problem of this fracture is because the blood supply comes lateral as the nerve supply. Arthrosis, remember the Heberden and Bouchard nodes on the swallowing of the hands. And the polyarthritis, apart again from the massive destruction, you have the ulnar deviation of the hand, and the hand again is like a swan. Okay, but the ulnar deviation, because the arthritis destroy these ligaments that joins the head of the metatarsal. Let's go into occiput because it's really important for us. So, basilar impression. This is a disease in which you have the entrance of the odontoid process into the foramen magnum, and is sometimes associated with the Arnold-Chiari disease. So, this is the occiput. This is the foramen magnum. So, as you can see on an MRI, the cerebellum is inside of the spinal canal. So most of these patients come to a practice with cervicalgia, with vertigo, even with the sore of the throat, and this is shown by chance. So we suspect from something more mechanical, and when we see an MRI, we see an Arnold-Chiari disease. This is a contraindication of the manipulation of the upper cervical. This is important, right? So here you see the cerebellum. This is an Arnold-Chiari grade 2 because it's going really low. This is a fourth ventricle. This is really important. So please make a screenshot of this. These are the standard measure for the upper cervical. You can choose whatever you need. So first of all, you can have this standard basal angle of 130 degrees. The easiest are gonna be the McGregor and the Chamberlain line. The McGregor line comes from the posterior part of the palate, of the hard palate, to the inferior part of the foramen magnum. And the Chamberlain is the same, the posterior part of the palate and the inner part of the foramen magnum. So here you see that is nearly normal, right? So if you go to in a basilar impression, the McGregor and the Chamberlain line are cut by the odontoid process. So this is a formal contraindication of the thrust for the upper cervical. If you find this, please do note manipulate. Another view of the basilar impression. You got an Arnold Chiari, a basilar impression, and here you got the Arnold Chiari, and this is a syringomyelia. Syringo means fluid in Greek, and this is a hollow cavity on the spinal cord, right? That is associated with the Arnold Chiari. So please do not trust in these patients. Again, Arnold Chiari, here the descent of the cerebellum inside the space that is for the spinal cord, and here you have a hollowness of the spinal cord. These are the normal views seen from in front. This is the B-mastoidean line. That is the line between the, sorry, this one, the mastoid processes. This is the B-digastric line between the two digastric groove of the temporal bone. And this is the Schmidt angle between the two mastoids and the two digastric and the odontoid process. This angle should be between 124 and 134 degrees, right? If you have a flattening of this angle and that lines are cutting the odontoids, this is a contraindication of the upper cervical. Let's see a question. Oh, Rabib, my pleasure. My pleasure. So here you got this measure. Please do not manipulate this patient. Again, what we told about the rheumatoid arthritis and pelvic spondylosis ankylosis. The atlas. Sorry because I didn't make this translation, but please, this distance should be 3 millimeters. That this distance shouldn't be modifying nor in flexion nor in extension. If this is a modification of this distance, is instability of C1, C2. Please do not manipulate the upper cervical, right? So this is a subluxation due to a turn of the transverse ligament of the atlas. This distance is bigger than 3 millimeters. Do not manipulate. And as you can see, in active movement, you see a difference of distance. So again, please do not manipulate. Fractures of the atlas. I'm not gonna talk about the fractures anymore because I think that you knew it. I tried to go into foot. Here you got ankle sprain. So this is the radiology we can use is the distance A and the distance B. I'm going to show you later on. This is the frontal view of the tibiotalar angle. Should be 20 degrees. If during a forced varus you have more than 20 degrees, means that you have a turn of the lateral collateral ligament. Here you see this is 43 degrees. This is a complete turn of the lateral collateral ligament. Okay, this is a forced varus. This is with a forced varus, with forced varus. Plus, as you can see here, the patient has a fracture of the distal part of the fibula. This is the measuring of the anterior bone, of the anterior drawer. So the point A is going to be the tangent of the posterior part of the tibia. Here you got it. And the point A is going to be the most posterior point of the talus. When I see the most posterior point of the talus, should be this, but this is the most posterior of the articular part. So this distance shouldn't be bigger than 10 millimeters. If it's 10 millimeters, it means that it's only the affection of the the talofibular ligament, And if the distance is bigger than 15 millimeters, means that the lateral collateral ligaments is completely torn. This is without drawer, and this is with drawer. This is a complete instability of the lateral collateral ligament. Remember when we saw the anterior talus bone and anterior impingement, a bimalleolar fracture. This is really typical with an ankle sprain, right? Fibular fracture. Here we have a test that is making an forced eversion. I mean, the patient referred pains could be a fibular fracture. Here you got the fibular fracture is really low here because this is not a fracture. This is the epiphysis of a patient. This is a young patient, as you can see. Here you got a fibular fracture. This is typical from the impact on the calcaneus, and you see the oblique line, more tibial fracture, plus this epiphysis. Here you got a clear view. This is really painful, a fracture of the cartilage of the talar dome. It could lead us into an osteonecrosis, osteochondritis dissecans, patient with constant pain. And this is osteopathically is associated with a compression dysfunction, okay? This is an osteochondritis plus an osteonecrosis. The problem with this is that these pieces of bone could be inside the joint and we can have like a locking and pain of the joint. Osteochondritis plus an osteonecrosis. Again, osteonecrosis. This is an affection, as you can see, of the dome of the cartilage. Again, in a frontal view and in a vertical view. Here we have to use the decompression, the tuck technique. Remember the tuck technique? The osteoarthritis with osteophytosis. The tibiotarsal tuberculosis is a real destruction of the joint, and is the patient should have suffered a lung tuberculosis. So it's going to be positive on the Koch bacille. Rheumatoid arthritis, a massive destruction plus lateral deviation. Remember, the ankylosing pelvis spondylitis starts with an enthesitis of the calcaneus. The severe disease is a dysfunction affecting, well, a disease, sorry, affecting kids from 10 to 12 years old that makes a lot of sports. And you have an epiphysiolitis. As you can see, this distal part of the calcaneus is more wide due to the traction. These some theories are associated with the not loosening of one of the primitive flexion of prehension with food. The spurs, the calcaneal, the heel spurs. Remember, these are related to a plantar fascia tension. Osteopathically are linked to a flattening of the anterior arch. So a dropping of the navicular and cuboid bones. This is a fracture of the neck of the talus. As you can see, this fracture of the neck of the talus, this during the First World War, they were called the pilot's fracture because sometimes landing wasn't so smooth, and you have pressure with the calcaneus, and the force was transmitted into talus. Let's continue. This is a subtalar subluxation. most of the times it's an hyperplantar flexion, like ballet dancers. Again, this should be the normal bolus angle between the calcaneus and the talus. Remember, here you got the 20 and 40 degrees, but sometimes it's used the complementary angle. So we may say 140 degrees. Anyway, any modification of this angle is going to be classified into talus valgus and talus varus plus fractures. As you can see, a flattening of this complementary angle tells us a fracture of calcaneus, right? You got a decreased bolus angle due to the fracture. This is normal, up is normal, down is a fracture. This is typical from, for example, from parachutists. As a curiosity, somebody told me that the Spanish parachutes from the army are narrower than other European countries' parachutes. So this is a real typical fracture because they have to make a real good technique when landing, right? Then you have a stress fracture of the calcaneus. A stress fracture, as you can see, instead of seeing this line of fracture, or this one, you see this is the body is trying to correct this stretch fracture because it's a micro repetitive fracture. And because it can be healed, this is the increasing of calcium on this area. You got again. Okay, so we talk about this, about dislocation. I mean, there's no problem for us because we're not gonna make this diagnosis. Ankylosing spondylitis, remember I told you there's an enthesitis, and this is really interesting to know it because it's the beginning, sometimes it's the beginning of the disease. This is a young male patient suffering from subtalar pain and this enthesitis. Raytis syndrome, remember this oculo-ureteral synovial syndrome? It also gave us this enthesitis on the calcaneus. This is an exostosis. This is an excessive traction of the gastrocnemius. So, and with a heel spur. So, well, this is typical for patients that making a an excessive workout. Calcaneal metastasis, this is a secondary tumor. So, as you can see, there's a destruction of the calcaneus. So the patient may refer pain and it's a night pain that doesn't get any rest. And this is a primary tumor of the calcaneus. So the difference, as you can see, this is a really destructive tumor. The Paget disease, this is an elder patient. And as you can see, there's a lack of, there's a destruction of the inner trabeculae. Fractures, okay, with fractures, I'm gonna be quick because I think they're easy to see. This is a fracture of the base of the fifth metatarsal. This is a stress fracture, what we would call in Spanish, we call it the soldier fracture because of the bad quality of the boots and the repetitive marching exercise. You see, and the body again is trying to repair a repetitive fracture. Once again, here is very typical on the shaft of second and third metatarsal bones. Right? This is a fracture of the base of the second metatarsal, not metacarpal. This is mainly for direct trauma. Osteoarthritis of the first metatarsal bone is a lack of balance on the internal arch. Okay, a falling of the internal arch. Well, as you can see here is an X-ray showing a flat foot. This is an increasing of the, or a decreasing, depending on the angle you consider of the Boller's angle. And this is an increasing of the Boller's angle. That is a pes cavus. This is a real pes cavus with a deformation in claw of the toes. Okay, significant cavus, an increasing of the secondary osteoarthritis and claw toe. And as you can see, the anterior part of the foot is below the calcaneus. So it means that it's going into a real cavus. X-ray flat foot. Flat foot are more related, remember, to obese people, fat people, and for example, the Afro-Americans or the African people, the Sub-Saharan people are more likely to have this flat foot as genetically. And related to this flat foot, you may have like an hallux valgus. Okay. Fracture of the navicular, no more fractures because I think you know the fracture. Sprain and luxation of the Chopard joint. This is the mechanism, for example, with ballet dancer or kicking a football ball. Hallux valgus is a deviation into medial of the first metatarsal and with a compensation of the first toe into lateral. Most of the times, the first toe is below the second one. Okay, so here you got it. With the bonnet, fixation of the bone. This is a direct trauma. Okay, fractures of the toe. Again, this is a direct trauma. Rheumatoid polyarthritis with the deviation into lateral. I want to show you goat. This is a distraction, and this is the crystals into the first metatarsal joint with a lot of pain. You got it, and distraction of the joint. So we're finishing this trauma, and I want to take you into, I think this is, okay, so I think we should go into the tumors, and if we have time, we can go into the disc problem, okay? Do you agree with that? So let's go with the primary malignant tumors. If I can find them, that would be really awesome. Here they got. So, primary malignant tumor, remember the characteristic of this primary malignant tumor is that has an excruciating and bearable local pain. The evolution is really quick, and the prognosis is always fatal. So the main common is going to be the osteosarcoma. This is a bone tumor. We have like two groups of patients. If the patients are young, because the metabolism is higher, the growth is going to be really, really, really quick. And you can find in patients 40, 50 years old, and of course, the growth is going to be like not so fast. Typical in cylindrical bones like femur, remember, and humerus, and flat bones such as the ilium. First of all, lytic lesions, destruction. The periosteum is going to be really reactive, and you're going to have like an onion skin or sunburn reaction. Okay, you remember this like an onion. Here you got the picture we showed before, right? Again, a quick growing and a massive destruction, as you can see, of the sacrum. So no matter if you don't know too much radiology, but you see that this is the iliac wing, this is to be normal, and something strange here. So we have to suspect, right? Look at this huge, massive tumor. So let me go into one of the most typical radiological pictures. This is the Hodgkin disease. This is a tumor of the lymphatic system, and it's going to give us this marble-like vertebra, okay, because it's more white than the other ones. Let me show you another one. So for example, this is a neurinoma. It's a tumor of the nerve root. So as you can see here, we have a real increasing of the intervertebral foramen due to a massive nerve root occupying this space. And this is a neurinoma of S1. Again, we don't know anything about radiology, but we know this is the root, the S1 root, and this is a huge S1 root. So it seems to be the tumor, right? And which are the secondary malignant tumors? Remember, we have to think of the cells we have in bone. We have cells that grow bone and cells that destroy bone. We have the osteoblast, and osteoclast. So we're gonna have tumors that create bone, we're gonna have tumors that destroy bone, and we're gonna have like a mixed tumor, right? So the typical one destroying is that you're gonna see, on the other hand, they are secondary because they are a metastasis. So the primary tumor is somewhere else. Most of the time close to the area. For example, if you have a dorsal secondary tumor, a metastasis, the tumor is gonna be, for example, is gonna be a breast cancer or a lung cancer, right? And if it's in lumbar, it could be like a prostate cancer. So here you got like a destruction. And in this case, you have creating of bone, right? Osteolytic or osteoblastic metastasis. And you're gonna see like a mixed. This is the osteoblastic. Remember the marble vertebrae. Here you got like white spots saying that something is not really good. And then the osteolytic, really typical is, for example, what we call in Spanish the blind vertebrae with no pedicles or the one-eyed vertebrae. So I'm going back to the beginning of my lecture when I told you that we have, although it seems to be obvious, but we have to know normal anatomy. And there's when we say, hey, where's the other pedicle? There should be another pedicle here. So this is a metastatic secondary tumor that is got into destruction, right? The pelvis, as you can see, this osteolytic and osteoblastic, this seems to be like cotton, but this, now we're a tumor, right? So I think, oh, my screen stopped sharing, sorry. I'm going back to the slides then. Sorry. you see the primary, you saw the primary tumor, don't you? So I'm gonna go into the secondary. There were here. And I'm gonna share that one. Sorry. Going back to my explanation. Now you can see, can you? So apart from all the symptoms you have to know from a tumor, perfect. Well, going back to the two cells that we have in bone. So here is the destroying, let's say, osteolytic tumor, and this is the osteoblastic tumor. So here you have destruction of bone, and here you have creation of bone, right? And you're gonna have like a mixed one. This is the mixed one, okay? A cotton-like. So here you got osteoblastic. This is a creation of bone. Again, the marble vertebra. And here you got, so we have to suspect, hey, what's going on in this vertebral body? It's spotted with more whitish parts. And this is what we call the blind vertebra because there is no pedicle and the one-eyed vertebra. Again, when we see this, going back to my speech, it's like, hey, we have to know normal anatomy and there should be a pedicle here. Where is the pedicle? So we know this is a metastatical secondary tumor. Then you got the rib metastasis. You know that this rib is not normal because you see these white and black spots in the pelvis. As you can see this cotton-like, so it's gonna suspect you. Most of these patients don't come to your practice, but if you see this, you know that it's a contraindication of the thrust. So I think this is all because for 2 hours it is a lot. I'm gonna, although most of you has my email address, I'm gonna write you down my email address. So any question you have about this, what I was about to say, seminar, this lecture, please let me know. We're gonna finish now because for Israel it's really late. It's like 10 by night. So I think it's enough. So thank you very much to all of you for being there, listening to radiology. And it's my pleasure being in contact with you, to be in contact with my Israeli and Canadian friends. Hopefully we can see each other next year because this year I think it's going to be difficult. And I wish you the best. I wish you health. Please don't panic. Remember, panic decreases your immune system. So be healthy, keep healthy, fasting, cold showers, no inflammatory food, and work out, right? So, my friends, thank you very much for your attention. I wish you the best and talk to you soon, right? I miss you, Guy. Remember, next week I was about to fly to Israel and my heart is really broken. So thank you all of you for your attention. And sorry if I went a little bit fast, but I had like 400, more than 400 slides. So it's far too much. This is for being done in 4 hours. So maybe one day we can make a complete seminar. So my friends Shani and Kushnir and Tamar and the Canadians, and Sarah, of course, and Jen. It's my pleasure. And I don't know who is the one in Haybreak, because I can see the the name. Okay, big hug to all of you. See you soon.